back to Cleveland for med school at Case Western, and then back to New York for residency at, where was it?
Oh, St. Vincent, Manhattan.
St. Vincent, Manhattan. I think so. That wasn't on here. Oh, yeah, it is. He then did his fellowship in allergy and immunology after a chief year there. He did his fellowship in allergy and immunology. Came here on faculty, is our pediatric clerkship director, the division chief for allergy and immunology, and is very involved with medical education otherwise. Anything else you want me to add? All right, so Dr. Lee.
All right, thank you, Kevin. Again, thank you for the kind introduction. I'm really excited to give this talk. This is something that I've been really wishing for many years. I gave grand rounds when I started on faculty in 2011, and I was on immune deficiency. That was my first grand rounds here, and at the end of that talk, I sort of said, the future for Kentucky is newborn screening, and that's sort of how we're seeing the future. And I'm pleased to say that Kentucky is now there. We are now newborn screening. We're in the pilot phase. We expect full implementation in 2016, this year. So again, I hope to tell you a little bit about severe combined immune deficiency and a little bit about the brief experience we've had in Kentucky, and again, some of the amount of work that's went into it and the successes that have come from it. So I'll talk a little bit about severe combined newborn screening. SCID newborn screening, and describe the method of how we do it. And that's the assessment for a particular marker for T cells called T cell receptor excision circles, or TRECs. Certainly, now that we're newborn screening, pediatricians will be getting reports of an abnormal TREC screen. So how are we going to deal with that information is one objective of this talk, and certainly every test has limitations. So I hope to, by the end of this talk, to at least tell you about some of the limitations of the test as well. And I think I mentioned one product here, but I have no disclosures that are relevant. So severe combined immune deficiency, SCID, is a syndrome of a very profound susceptibility to essentially any infection. It's a complete loss of function of the immune system, and it's primarily due to a defect of lymphocyte development, particularly the T cell, and we'll talk about that later. I'm going to tell you that historically it's been thought to be a pretty rare disease. The most generous estimate in the past, before the era of newborn screening, was 1 in 100,000. And I'm going to present you data that has shifted over time since we are detecting this more accurately and earlier. The first report of SCID was back in 1950. It was done by a Swiss physician named Glanzmann and his partner Rinneker. This is the same Glanzmann responsible for Glanzmann thrombocythemia, the platelet defect. And what they described was 2 infants who died very early in life with severe infections at 5 to 6 months of age. And they had a peculiar finding of complete absence or very, very low lymphocytes in the bloodstream and no lymphoid tissue, including the absence of a thymus. And so they described this syndrome as essential lymphocytosis. And again, that was sort of the Glanzmann-Rinneker syndrome as it was described in the 50s. And so over time, through the 60s and 70s, we started to recognize what this syndrome is. And it was babies who unfortunately appear 100% normal at birth. Many of these children had no outward physical sign of any medical issue, but they declared themselves as they got older. And what we expected in the few weeks to months of life is that they would have failure to thrive associated with a multitude of infections. And that would include very common infections such as otitis media or pneumonia, but these would be more persistent, more severe. But again, the big warning sign was multiple or opportunistic infections, including pneumonitis, that could be viral, pneumocystis, chronic diarrhea, candidal infections, either in the diaper area or persistent thrush in the mouth, which was hard to remove, and then sometimes bloodstream infections like sepsis. these patients would have, again, in the original description, no evidence of lymphoid tissue. The most surprising one would be the absence of tonsils in a child who's chronically congested. And then they would have an absence of the thymus. So again, if they did a chest x-ray to detect pneumonia, they would not see a thymic shadow. And that would be a very surprising finding, as you'd imagine. And so lymphopenia is a cardinal feature of this syndrome. And so I always want to take this opportunity to talk about the importance of lymphopenia. We see tons of CBCs, like innumerable CBCs. And I always wonder, are we actually looking at all the information that the differential gives us? So just if you just take a look at this, I'd like you to think for yourself. I decided to remove the audience response areas. What is the lowest, what number is closest to lower limit of normal for an absolute lymphocyte count in a newborn? And obviously we look at percentages and stuff like that. I sort of, in a sort of sarcastic fashion, I do believe a lot of residents look at the neutrophil count. We love the neutrophil count, left shift or not there, and then you call it a day, right? But the lymphocyte count, gives us a lot of information. And so the correct answer, again, I'm not going to put anyone on the spot, is 3,000, right? And so, one response to this is, well, certainly, okay, it is 3,000, but, we got the little normal ranges. We'll just look at the normal ranges, and that's how it goes. Well, let me tell you a story. There was a patient admitted at Kosir Children's Hospital in June of 2015 who had a lymphocyte count that looked like this. This is this patient's CBC. This patient had thrombocytosis, had that sort of elevated seg increase with 9,000 ANC, but had a lymphopenia of 2,000. This was a 1-month-old infant, all right? I want to bring your attention that the normal range for the lymphocyte count was 1,500, so this was not flagged as low. When we trend the lymphocyte count, there was multiple lymphocyte counts throughout the entire NICU stay that were not flagged as low, but were clearly under the 3,000 I told you and toward the end of the hospitalization. If you did a lymphocyte subset on this infant that was in our hospital that had a lymphocyte count that was not flagged as abnormal, that was the lymphocyte, that was the T cell subset. So again, there's 3 flavors of lymphocytes, right? There are T cells, B cells, and natural killer cells. So I told you the absolute lymphocyte count was 2,000. The patient had 1,400 B cells, about 500 natural killer cells, and 0 T cells. The T cell count was 0. There was not a detectable T cell count in the patient. All right? So if there's one message I do want you to walk away with, okay, there's 2 messages, but one of the primary messages I do want to walk you with is, please, the differential on the CBC has a lot of information. And one of the pieces of information that you have an opportunity to intervene on in an infant is lymphopenia. Now, transient lymphopenia does exist, right? There's medication-induced lymphopenia due to corticosteroids. There's viral-induced lymphopenia. But in the patient who is ill, who in the first year of life, you might want to ask the question, could this be a common manifestation of a rare disease, and you have it in built-in blood test before they are newborn screening that was widely available, that unfortunately sometimes we are not detecting. Obviously, I discussed this with our immunology lab director, and we're getting it fixed, all right? But I'm just letting you know that this was something that really surprised us, all right? And this is something we should all keep in mind. The lymphocyte count is very important information for the detection of severe chronic immunodeficiency. Sometimes that is one of those opportunities, if we talk Swiss cheese model, that sort of thing, where we could intervene early on these children. So why do SCID happen? What is the etiological cause of severe combined immune deficiency? As you know, our entire immune system develops in the bone marrow. Hematopoietic stem cells maturate into a common lymphoid progenitor, and one of those lymphoid progenitor becomes a T cell. That progenitor, that pre-T cell, goes into the circulation, and it's heading to one place, and that is the thymus. The T in T cell stands for thymus, right? And so the thymus is the location where the T cell undergoes its development, right? So once it migrates from the bone marrow to the thymus, 2 things happen. Number 1, that T cell actually recombines its own DNA to make a unique T cell specific for one antigen, right? And we have millions and millions of T cells that all are unique. You have a broad diversity that you all make from scratch in the womb and through birth, right? And so that means that every single permutation of a bacteria will be recognized by a T cell in your body, hopefully. Otherwise, then you have like those doomsday scenarios on TV and that sort of thing. And the combinatorial diversity is massive, much higher than the Powerball lottery, right? So we're talking like 10 to the 15 combinatorial possibilities, right? So once we generate a unique T cell receptor, we got to do a little quality control. Does the thing work, right? And so we have this process of positive, negative selection. Positive selection, does it work? Negative selection, does it work so well that it's going to react to everything? So we let this thing out, and it's going to attack us, right? We don't want it to work too well. So this is sort of this Goldilocks principle where it's got to be just right, right? It's got to work, but not enough that it'll be autoreactive or autoimmune, right? So if we convince ourselves that this is a T cell that's of high quality, the thymus kicks it out. Oh, I'm sorry. If it's a bad one, we get rid of it, right? And the graduates have a degree. They're naive T cells, and they have a marker. It's called CD45RA. Now, there's defects that can lead to the problems with generation of T cells. And these are the etiology of severe combined immune deficiency. First of all, it could start very early in maturation in the bone marrow, early progenitor phase. For example, we have receptors on the cell surface that get signals required for its development. So interleukin 2, interleukin 7, these are messages that the T cell receives that tells it that, yes, we want you to make a T cell, we want you to develop. Any defect in the signaling or the receptor itself will cause an arrest of maturation. The T cell will never develop. Again, T cell count of 0, right? I told you the thymus is important. If you're born without a thymus, there's nowhere for that T cell to go. It's just going to float around and die, right? And so the presence of a thymus is essential for T cell development. As you know, the classic disorder of athymia or hypoplastic thymus development is the DeGeorge anomaly. Most common mutation, a deletion in 22q11. But certainly the CHARD syndrome, secondary causes like infant of diabetic mother can lead to complete thymic hypoplasia or aplasia. But the third problem in that maturation from beginning to end is a problem inside the generation of the T cell receptor. And again, this is a very complex process where the immune cell rearranges its own DNA to make a unique receptor. So any problems with DNA rearrangement or recombination, any problems with nucleotide generation, so adenosine deaminase is very essential for the purine metabolism pathway, and this is highly expressed in the thymus. So anything involved in DNA recombination, essential genes in that, or the receptor itself, can lead to, again, arrest at the thymus development. So again, luckily, most of us make to the finish line, but mutations along the T cell maturation pathway can lead to an absence or decrease in the number of T cells, right? And again, this is a very busy slide, but essentially I'm telling you that you want the stem cell to go all the way to the end, to the finish line, and make a CD4 positive T cell. And every red line here, again, is an opportunity, unfortunately, where there can be arrest of maturation and therefore an absence or decrease of T cells. And the interesting thing is that some mutations only affect T cells, but some mutations affect other cell lines. For example, you could see here that the RAG mutation affects B cell development and T cell development. And so what we have an opportunity then is to classify severe combined immune deficiency based on what cells made it to the finish line, right? So severe combined immune deficiency is actually classified by what lymphocytes are present. So I showed you an example of T minus, B plus, NK plus SCID. The patient did not have T cells, but made B cells and natural killer cells. So we think of thymic defects or IL-7 defects. But, RAG defects would be you lose B and T and B cells. the classic X-linked disorder, which is X-linked SCID, you'd have no T or no NK, but you'd have B cells. And so we use that information. It helps me classify severe combined immune deficiency and determine where in the pathway, where in the steps of development did the machine break down and the T cell died. So when we identify SCID, like the patient I just showed you, let me tell you, again, the wheels started moving. We brought that patient in immediately. Because severe combined immune deficiency, if confirmed, is considered a medical emergency. We do know that if the patient does develop infection, they are highly at risk and highly susceptible without protection, right? So we initiate a couple protective measures in every patient with severe combined immune deficiency. Certainly, you'd want to rule out the differential diagnosis, which would be congenital HIV. But certainly, you would also want to do that lymphocyte subset enumeration. We call it immunophenotyping at COSAIR. And you'd want to be able to classify the type of SCID based on the T, B, and natural killer cell number. Your expectation for SCID patients is that the T cell count will be very low. And again, I showed you those little graduates, those naive T cells. Those will be low as well. Certainly, we can do functional tests I won't get into, called a mitogen stimulation. And then based on the T, B, and natural killer cell pattern, we'll direct our genetic testing from that. Though sometimes, not every severe combined immune deficiency patient presents the same way. So we have the opportunity to do next-gen sequencing I'll talk about in the next slide. So again, the initial management of severe combined immune deficiency would be, obviously, it starts with protective isolation. That patient would probably would be shielded either in the home, their siblings. They probably have to, the siblings who are sick probably would not have to be exposed to the child. You would have to, again, reduce the frequency of infections as much as possible. You would initiate antibiotic prophylaxis. The most common one, as you know, would be receptor or trimethoprim sulfa for PCP prophylaxis, though fungal and viral prophylaxis has been used as well. B cells are activated by T cells, so they would require immune globulin replacement. So we would start either intravenous or subcutaneous immune globulin replacement and give them IgG. And we do know that some mothers can transmit CMV infections through the breast milk. So usually, if a child is suspected to be of SCID, we do want to assess the CMV status of the mother. And again, if they are risk for CMV, we would not breastfeed the child for risk of transmitting that to the baby. Certainly, live viral vaccines are contraindicated in severe combined immune deficiency. As you know, the earliest one we could give to infants is the 2-month visit. We give the oral rotavirus vaccine. And it was interesting, after the release of the oral rotavirus vaccine, initially, there were several case reports in the New England Journal and the Journal of Allergy and Clinical Immunology of severe combined immune deficiency detected by persistent rotavirus infection from the vaccine. Not the best way to detect SCID, unfortunately, right? But again, we'll talk about that later. And then certainly, you would not want to give the child any live lymphocytes. So you would want to irradiate cells to make sure you are not actually giving live lymphocytes to the child for the risk of a graft versus host reaction. So I mentioned that now we have the technology to screen multiple severe combined immune deficiency genes at the same time using next-gen sequencing. And the rationale for that is you want to get a specific diagnosis as soon as possible to facilitate prognosis and also initiate a definitive treatment. And so, again, this is one example of a panel that's available that screens multiple genes at the same time, including some of the ones I mentioned on the earlier slide. So, what is the standard of care? Well, again, even despite prophylaxis, most severe combined immune deficiency patients will not survive. So the standard of care is curative therapy through a couple different interventions. The primary intervention is hematopoietic stem cell transplantation, which you, again, restore T cells by transplanting normal stem cells into the child, and where you perform HLA typing of the child relatives and then a donor search as well, where, again, your best case scenario is that you have a full sibling matched candidate where we can, again, again, do the transplant with. Now, again, there are other experimental treatments depending on the type of immune deficiency. The child that I described before with the George anomaly, if you gave that patient a transplant, that patient still has no thymus to go to. So again, sometimes the preferred therapy for that situation is to do a thymus transplantation, or we'll talk a little bit about gene therapy. Gene therapy is now available on an experimental basis for immune deficiency, where we can actually use a viral vector to place the defective gene back into the stem cells and reinfuse into the patient. So what is the prognosis of curative therapy? We know from the Duke cohort that the timing of bone marrow transplantation has a massive effect on the prognosis and the natural history of this condition. And this is data from Rebecca Buckley that's demonstrated that of the 46 SCID infants who were transplanted before 3.5 months of age, the long-term survival, this is up to 24 years post-transplantation, was 96%. If you transplant after 3.5 months of age, the survival was 66%. There was a massive difference depending on how early you initiate transplantation. And the belief is that once a child accumulates a certain number or burden of infections, it complicates the transplant procedure and, again, increases the likelihood they will not survive. And so the justification for newborn screening is partly due to the essential need to initiate curative therapy in severe combined immune deficiency as quickly as possible. And so when we think about what criteria we use to do severe combined immune deficiency screening, we have a couple sort of set parameters that are widely accepted. Number one, if you're going to pick a newborn screening test to invest in wide populations, it has to be a condition that is asymptomatic at birth. And I already told you that severe combined immune deficiency patients can look absolutely normal at birth. And certainly infections might take a while to develop because the mother does give immune globulin to protect the child. And obviously, as the immune globulin wanes from the mother, usually around 3 to 6 months, that's when the infections may develop. And by that time, certain infections, i.e. that 3.5-month mark, may have already hit. Secondly, is there serious medical consequences about treatment? And universally, severe combined immune deficiency is almost always fatal in the first year of life. And so certainly we are trying to detect a fatal condition. Now, again, I told you that we have good confirmatory tests. We have the lymphocyte subsets. We have next-gen sequencing now to screen multiple SCID genes at the same time to get a rapid diagnosis in the patient. And I told you that early interventions can lead to outcomes. And so it was proposed back in the mid-2000s that severe combined immune deficiency met all the criteria we typically use to make the decision to perform newborn screening and make that investment in large populations. And so the technology that was developed and the type of test we decided to use for SCID was this assay for T-cell receptor excision circles. So let me explain this for a second. So again, to make a transcript of a T-cell receptor, you need certain genes that are spliced together. And how do we get the diversity of different unique T-cell receptors? Well, we have multiple segments to choose from. And so if you choose a card from each deck and you shuffle the deck, you have multiple combinations that can occur in sequence. And certainly what you can do is that if you pick a V segment and a J segment and remove the intervening DNA, you will develop a wide array of different T-cell receptors. And so what happens is that the body will sort of loop the DNA upon itself and sort of snip at a certain unique sequence here, leading to things. You'll have the transcript for the T-cell receptor. That's what the T-cell will make. And then you have this sort of leftover DNA that doesn't go anywhere. It's actually quite stable and just sort of floats around there. And that leftover DNA is what we utilize to detect T-cells. And so if you think about it, every single newly fresh T-cell that is released from the thymus has that little loop of DNA inside of it. And so essentially, if every single lymphocyte has that loop of DNA, detecting TRECs is essentially getting a T-cell count on a child by doing a DNA detection test rather than a blood count. And so essentially there is a correlation between TREC count and the number of T cells. So this is a slide borrowed from Jennifer Puck. We take the standard Guthrie card, and we, again, take that little punch from it. And what we do is we do a DNA extraction to get the DNA out of the blood, including those TREC DNA. And then we use real-time polymerase chain reaction to detect that little DNA sequence. And so this is pictures from the Frankfurt Newborn Screening Lab. This is sort of our hole puncher here. So again, we're taking Guthrie card strips, and we're taking those little blood spot punches. We do a DNA extraction process where we take the DNA out, and then we add the master mix in order to do the polymerase chain reaction. And then we put it into the real-time machine, right? So again, we have sort of this setup in the lab where every single blood spot is screened for this particular unique DNA sequence that is a surrogate of our T cell count. And so, again, we use a technology called real-time PCR. I think we're all familiar with PCR, which is we have specific primers for a unique DNA sequence, and over time, we repetitively, again, heat and cool DNA, and again, amplify a certain region over time. And so this is one example of how real-time PCR is done. If you have a dye that only binds to complete DNA strands, as you amplify DNA, your sample is going to start glowing, right? And if you reach a certain threshold, then we know that they have, again, a certain, percentage, or content of that DNA sequence. If you start with more TRECs to begin with, the quicker you'll get, the less cycles it needs to take to detect that sequence. So the earlier you detect it in the repetitive cycles by real-time PCR, the more TRECs you had to start with, all right? Very late amplification, i.e. it took you a long time to bring out these little sequences, suggests very, very low TRECs. And so this is what a typical amplification plot would look like. So this is that glowing fluorescence, right? And so this is number of cycles. So 1, 2, 3, 4, 5, 6, 7, 8. And so we do it over and over and over and over and over and over again until, again, we start detecting those glowing double-stranded DNAs. And then we reach a certain threshold, which we call the CT. And whatever cycle it takes to cross the CT is what we define as our surrogate for the TREC count. So again, if you have a lot of TRECs, you'll amplify really, really, really soon over here. If you're very low or absent, it'll take many, many cycles. You could go up to 40 to 50 cycles and, before it amplifies, right? And so we're really looking for, the most ideal scenario is that we detect the DNA sequence very early when we do real-time PCR. So let me tell you about Dawson. Dawson was born in Wisconsin in June 12, 2008. And 12 days after he was born, she received a call that she failed this newborn screening test for SCID that was not advertised. She didn't actually know what it was. But interesting, that evening, he had a fever, and so she was advised to go to the hospital, and he was diagnosed with umbilitis and skin abscesses. Well, his lymphocyte count, again, was consistent with SCID, and he was diagnosed and transplanted in September 25, 2008 from a German donor. This is the first child detected by newborn screening back in 2008. And again, this is old data from 2010 when he was 2 years old. So obviously now he's 7, all right? Still alive, still thriving. And again, sort of more children have been detected through this methodology over time. And the Wisconsin data suggests that if you estimate that late SCID diagnosis with recurrent hospitalizations or morbidity and mortality and the complications of transplant, one possible cost estimate for a late diagnosis of SCID could be upwards of $2.2 million. Though, if you do it very early, you can, the cost could be low as $250,000. So the delta in costs, and considering each screen is $4 to $5, if Wisconsin screens 70,000 live births a year, the cost of the program was $350,000 per year, or essentially the cost savings of one SCID could pay for the program for multiple years, right? The overall health cost care savings by detecting SCID early. So if we look at the aggregate, this is an old slide, but if we look at the aggregate data from California, New York, or multiple newborn screening done in different states, if we look at the data, I told you that the previous estimate for severe combined immune deficiency was 1 in 100,000, and now new estimates suggest that it's 1 in 50,000. And so if we expect that Kentucky has around 50,000 births a year, we would expect one severe combined one SCID patient to be detected in Kentucky a year. And again, Jerry and I were just talking. We recall maybe like 2 or 3 SCIDs in maybe the 20-some years of the ID group here at Coast Air Children's Hospital. And so there's a remarkable delta, and certainly we don't see the entire state, but we wonder where these sort of yearly SCIDs have been going, and is it possible some of them were not caught early enough and unfortunately passed away. So, in terms of the number of SCIDs and types that's been detected, again, the distribution is, again, the X-linked version or gamma chain is probably about a quarter. It's probably the most common type of SCID, and this is the California group. If you look at the more nationwide group, it's more of an even mix of the X-linked version and then, again, an enzyme defect called RAG. Though there are plenty of new undiscovered reasons for lymphopenia that we are, again, now learning about, detecting early, and again, using that knowledge, and now we have technology like whole exome sequencing to determine new types of SCID and furthering our understanding of about the immune system. So there are other reasons why the lymphocyte count can be low that obviously the SCID screen will pick up. The SCID screen, the TREC screen, only is really detecting a lymphocyte count. So really, any cause of lymphopenia in an infant will be detected by the test. So what are some other causes of low lymphocyte counts? Well, if you receive a blood transfusion, you sort of diluted out the lymphocyte transiently, right, before it normalizes. So usually in our protocol, if someone has gotten a transfusion, we usually wait a couple weeks before we and then repeat the test. Very extreme prematurity, the data suggests under 2.5 grams birth weight or very early gestational age can be a sign, can lead to lymphopenia. That, again, would be expected to resolve over time. So, as you know, the lymphatic fluid is enriched with lymphocytes. So patients who develop a post-surgical chylothorax, the most common situation is cardiac surgery. Lymphocytes are literally going to the pleural space and are being sucked out into the chest tube. We're not detecting that in the peripheral blood. So if we do a blood spot, those patients are going to have very, very low lymphocytes. And I think we had a patient like that a couple of years ago. And then, of course, there is the chance of congenital leukemia or malignancies very early in life that can lead to lymphopenia as well. Now, Down syndrome, interestingly, can be associated with lymphopenia at birth. I'm not saying Down syndrome can always have immune deficiency, but again, it's in the differential diagnosis of lymphopenia. I told you about the DeGeorge anomaly doesn't necessarily have to lead to SCID. I showed you one example that was SCID, but actually the majority of the DeGeorge patients we see have some sort of partial thymic function. So, they're on this continuum of a lowish lymphocyte count, but not completely absent. If the lymphocyte count is low enough, we'll be able to detect it. So we could pick up the DeGeorge with this screen somewhat. And then, unfortunately, rare SCID types, very mild SCID types, can start with a normal lymphocyte count, but have a functional defect. So this would be a late onset ADA. There's an MHC deficiency called a bare lymphocyte syndrome, certain DNA repair defects. These can be causes that are missed by the screen. Again, are opportunities for further investigation. So, but despite all of the limitations, again, given the sort of positive results for the initial trials, former Secretary Sebelius recommended TREC being added to the core panel for universal screening back in 2011. And at that time, there was very few state screening. This is the most up-to-date map from November 1st, 2015. where, again, the majority of the country has adopted the universal recommendations for combined immune deficiency screening. And again, I'll tell you a little about Kentucky's experience last year. So what did we do? So again, I sent out an email to, when I started on faculty, say, hey, what's going on with this? This is something I want to get involved in. It's like, well, we're talking about it, and come back to us later. I'm like, okay. And then so I kept on prodding them like every single year. And again, as the sort of culture changed throughout the country, how the importance was emphasized, they actually made the investment to purchase the instruments. I got this call back in September 2014 saying, hey, you've been bugging us for many years now. Hey, now we're interested in doing it. So could we meet? So they purchased the instrumentation for the screening. And actually, the CDC has sort of been taking a lead role in the education and the training for this. So multiple members of the Frankfurt group traveled to Atlanta, and they were trained on the program. They developed controls. They collaborated with other existing programs to do side-by-side, screening to validate their own processes. We had our first conference call in October of 2014 to go over the testing algorithm. To be honest with you, the testing algorithm, I just basically called everybody I knew and looked at, what are you doing? What are you doing? What are you doing? And I had like 4 different protocols, and I just sort of did a mishmash of the ones that I thought made the most sense. They successfully got an APHL grant, so the pathology laboratory gave out $300,000 for the implementation of this. Kentucky was one of the few states that actually received this grant earlier this last year. And then we started validation of not live samples, but of the controls that we developed. So after about a year from the arrival of the instruments and the training and, again, practicing the techniques, we actually started active newborn screening for SCID on August 3rd of this year. And so where did that leave it? Okay, so what do we do? Okay, so every single patient, again, in Kentucky that is born gets that TREC screen on the punch that I showed you. We do real-time PCR, and again, if the crossing point the threshold is very low, and we use a housekeeping gene, so again, RNase-P should be in all of our cells. So again, let's say the sample's bad. Then the housekeeping gene will be very low. The sample may be invalid, right? So if the housekeeping gene is normal, and it's very, very low crossing threshold, then it amplified early, so the patient probably has plenty of TRECs, is a low-risk patient. Now, certainly, anything that's abnormal, we're going to repeat it. And again, if they get the same normal result on repeat, if we have a normal result on repeat, then we just say that they're low risk. Now, there's a couple situations that can happen if the repeat is abnormal. Situation 1 is the housekeeping gene is abnormal. So one situation is that it doesn't amplify, which means there may be no DNA in the sample, right? Again, bad blood spot or poor sample. We're going to have to ask for a repeat specimen. Another situation is that sometimes 2 of those little punches can just sort of, by static electricity, fly into the same well. So then you'll see double the amount of housekeeping gene, right? So we have to, again, repeat that sample. Situation 2 is sort of most clear, right? If it doesn't amplify, if we just do multiple cycles and we can't get anything out of the sample, or it amplifies very late, that is highly abnormal. I hear about those patients. Tiffany gets a call about those patients, right? And of course, the housekeeping gene is normal. And so what do? We get that call, right? So again, Tiffany is our SCID coordinator. When she gets that call, she notifies myself, and she notifies either the primary care physician or the NICU attending. And so we give a couple instructions. First is that, again, we have to protect the infant. We advise that we isolate them, keep them at home, no daycare, no exposure to ill family members. And honestly, we don't actually want them to be exposed to other sick children. We don't want them to go to the ER. We don't want them to be hospitalized if we don't have to, waiting in the pediatrician's office, that sort of thing, right? So we try to isolate them the best as we can. obviously, if the child's sick, they must be evaluated. Right now, we'll take precautions before they come in. But again, any sort of illness must be evaluated. We mentioned, again, the recommendation to do irradiated leukocyte-reduced products to avoid CMV infection. And, of course, avoiding all live viral vaccines, including the rotavirus. And so we need to confirm the test. So we do a blood count with differential. We do that TB and natural killer cell count to get a T cell count. And we look for those naive T cells I showed you. So we do a CD45 RARO. And then so that patient usually sees us within a week, or their local immunologist, or we discuss it over the phone if they're already in the hospital. So how about these sort of so-so ones? So let's say you're not normal, but you're not terribly abnormal. You're sort of in between. So sometimes we're getting results that we think are maybe lymphopenia, but not complete SCID. And so there's a couple situations that can occur from this. So one possibility is, remember, very extreme prematurity. So children who are under 2,500 birth weight, we actually go ahead and repeat the sample in 2 weeks. If they just got transfused, we repeat the sample in 2 weeks. But again, even if they're in the sort of the intermediate phase and it's a full term, it could have been a bad sample. We repeat it immediately. And obviously, we'll still give the same advice of avoiding illness, evaluating if ill, again, irradiated, leukocyte-reduced, CMV-negative products, and not giving live viral vaccines. Now, again, a lot of these repeats can end up being normal. But, again, when we get that second specimen, if the repeat is normal, then we call it a day. If the repeat is abnormal, or in that sort of mid-range, we will consider them high risk and we'll get that call. And again, when we do that 2-week repeat, we usually do it one more time. If the third repeat is abnormal, we will be called, right? And that's because we're accounting for the fact that, again, premature infants will have a lymphopenia for quite some time in a lot of cases. So in Kentucky, since August, we've done 23,921 samples. Again, we have about 50,000 live births a year. We had 366 that was above the cutoff required retesting, right? That initial retesting algorithm, right? Of the yellow algorithm, 40 were considered that moderate risk, either premature, blood transfusion, or inconclusive. We repeated those tests, and at least of the ones that we've repeated, none of them has ended up being the high-risk protocol. But we've gotten 5 calls, and those are the ones that were 99.5 percentile out of range. 4 out of 5, we did the repeat, and the lymphocyte count was normal, and the CD4 count was normal. So I said 4 out of 5. What about the other 5th? All right, so let me tell you about that. Okay, so this always happens on a Friday afternoon. I mean, that's how it's going to go, right? So we got this call from Friday afternoon. Tiffany comes to my office, and I said, okay, well, there's an infant in northern Kentucky who has an abnormal TREC strain. Okay, well, let's contact that PCP, get a CBC, and a lymphocyte count. I'm sorry, the lymphocyte subsets. Well, you know, the flow cytometry lab is closed over the weekend. Okay, well, let's do it Monday, right? So, again, they don't do a T cell count over the weekend. So we said, okay, on Monday, get the CDC with blood count, lymphocyte subsets, the RARO, isolate the infant, usual recommendations we did for the high-risk protocol. And so on Monday, Tiffany bursts into the office, right? And she shows me this, right? So the total white count in the infant was 4, and the lymphocyte count was 10% or 400, okay? 400 is low. I think we're like, that's low. That is low. 400, all right? That is impressive, all right? If you want to know what the lymphocyte subsets looked like, they repeated it again. It was 0, by the way. The CBC lymphocyte count was 0 on repeat. This was the lymphocyte subset report. Well, again, it says too few lymphocytes to accurately report results. Okay, that's abnormal. That is not normal, okay? So, anyways, that got our attention. Again, I trained in Cincinnati Children. I called my friend Linda Carl. She arranged for him to see at that immunodeficiency clinic. They do it every Wednesday. So she saw my friend Yeşim Küçük. She is sort of like this hyperactive, very bright Turkish immunologist. I love her. And she saw her on Wednesday. That testing was consistent with negative SCID. We sent, and that we were suspecting ADA deficiency. She sent the enzyme activity assay to Dr. Hirschfeld and Duke. 2 days later, he called us and said there was no ADA enzyme activity. So if you want to think about this, the big picture is from we got notified on Friday afternoon to when Dr. Hirschfeld called Yeshim on Friday, the week afterward, the child was diagnosed in a week, all right? And the diagnosis was ADA SCID. I want to tell you that was immensely satisfying. I couldn't believe it. It was, I mean, I just could not believe that the child was diagnosed of a critically life-threatening condition in a week, right? And a child who was maybe had a respiratory thing, I think had a little bit of a respiratory thing that week. But overall, before any other serious infection occurred, the child was barely a month old. All right. So, that was really exciting. So that child, again, you can give enzyme replacement. That child's on pegylated ADA. And, unfortunately, this child does not have a matched sibling. Right now they're weighing their options. One possibility is to enroll in a California gene therapy trial where they're actually using, again, that viral vector to introduce the ADA gene into the stem cells and transfusions to the patient. So again, we'll have to see what they end up doing. They're still deciding their options. The child is on the pegylated ADA but still has lymphopenia, so it needs prophylaxis and so on. It's not a panacea, so we're going to need to have curative therapy. So, to conclude, severe combined immune deficiency is this sort of syndrome that's been recognized for over 50 years of profound susceptibility to multiple infections. And the scary thing about SCID is that these babies look beautiful and normal at life, but it is a fatal condition if untreated, and that's my fear, that historically there are millions of babies that may have been undetected by normal clinical, measures because of how insidious this condition can occur. And so we are newborn screening. I'm pleased to report we expect full implementation this spring. Again, we have one positive so far, which, again, I told you about. And, again, I expect more, at least once a year or so on. I'm just telling you about this. I mean, we're on a couple conference calls and sort of maybe a couple meetings in Frankfurt. The real people who have implemented this is the group in Frankfurt. This is from the Department of Health. Leah Mott is the head of the newborn screening division, and Darren is head of the section of newborn screening SCID. The hands is Tate and Jen. They have, again, laboriously go through every single sample in the state of Kentucky. The pathology group at UK has had an active role in development of the process. That's the chief, which is Daryl Jennings, and then Siva Arumagan as well. And so I love Christy and Tiffany. They're fantastic. I think, Gary, Jerry, you have just an incredible group there that, again, has run immune deficiency beautifully for years. And, again, they're sort of like the way that everything gets done, and we, again, protect these babies. And Tiffany and I were really excited when this occurred. And, again, one thing I do want to emphasize is that this is a Commonwealth-wide initiative. This is not, U of L. This is UK. This is the Department of Health, and this is us. We're all working together to make this happen. So, again, it's been immensely satisfying to act in that role as well in this statewide initiative. The last thing I want to leave with is that historically the Immune Deficiency Clinic has been every first and third Friday run by pediatric infectious disease. And that's because I've only been here for 4 years and I barely knew where the bathroom was. I'm sort of new here. So again, I sort of figured things out, I think, a little bit. And so we're sort of making a transition to the clinic under my supervision. Again, the location will still be in the 6th floor suite in 602. And Christy and I will be the main providers with infectious disease attendings coming if they're available, which would be great if they are. I know they're really busy. But you would call my office actually to schedule that. That, again, I think will occur in February 2016. It is not 100% official yet. There's the usual credentialing and sort of barriers. But again, we are establishing or growing, again, immunodeficiency presence. We are the referral center for newborn screening for the entire state of Kentucky, all right? Every single positive screen we know about, and then we are the primary follow-up facility. Again, the kid I sent to Northern Kentucky to Cincinnati is because they were basically 20 minutes away from the hospital. So again, I didn't want them to drive an hour and a half over to hear us. But otherwise, we are the primary facility for the state of Kentucky. All right. So that's really the end of my talk. I'd like to answer any questions if you have any.
That was a wonderful presentation. First of all, I'm going to start looking at lymphocyte counts in the newborn. I wondered whether in families that have a positive history, whether antenatal diagnosis is possible either by cell-free DNA or CVS or percutaneous umbilical blood sampling?
Oh, absolutely. Once we know the genetic defect, we can certainly screen for the condition. In fact, some people have been sort of considering, can we do a perinatal intervention? Again, very experimental, but that's sort of the considerations, for, again, to protect these children as much as possible.
Right.
Absolutely.
Great.
I agree, Jerry. You did a great job. I really appreciate all the work you've done over the past several years to get this in motion and to get it accomplished. This is a really huge, huge thing. Most of the country is doing it, and everybody's looking at it, and I think it's going to be wonderful. I, like you, when you first came, I think we talked a little bit about where are all these babies?
Yes.
Because in my prior places where I was, we had many children, too many, obviously. I never like to see them, but we did have the usual numbers of SCID babies, and I've transplanted many of them. So I look forward to working with you. Obviously, I need to reiterate that we, as a group in bone marrow transplant, are ready, willing, and very able to do these transplants. We are part of a national group called the Pediatric Blood and Marrow Transplant Consortium. We call it PBMTC, and they're already querying me for our data, for our information. We do have national protocols that we utilize. So, the type of transplant that we do is a standardized type of transplant, very much geared to the type of SCID baby that we have. And there's a lot of things that go into, and Jerry knows about this. It's obviously way above what we need to talk about this morning, but there's lots of different things we need to look at to determine the appropriate type of transplant for the babies. Some of the babies, in the best of circumstances, absolutely need even no conditioning at all. So those transplants are actually very quote unquote easy. So forgive me for maybe downgrading that, but all of them have their risks. But in the grand scheme of transplant, this actually is one of the best types of transplants to do. So we're really looking forward to this. And again, I congratulate you on a great talk and all the work you've done. We really appreciate that.
Okay, thank you.
Thank you.
Just a quick question. I noticed that Indiana is not screening so
No,
far,
it is not.
which is bonus fun. And I also wonder, just from a public health perspective, how we're trying to push into communities that may be doing more home births or other types of things where they don't necessarily have that newborn screening done at the same time or at all, compared to other populations like some of our Amish populations and things like that, where we may even expect more genetic types of issues.
So for Indiana, the IDF approached me. I gave a talk at the IDF about a couple months ago, and they are just red hot to just kind of get it moving. And so again, I'm collaborating with some of the Immunodeficiency Foundation members locally to again advocate for newborn screening in Indiana. I'm sure they get immunologists over there, but again, obviously there's some barrier I'm not aware of. In terms of the home birth thing, again, that's out of my expertise. I don't know if Kara Gooden here or someone else knows about some of these things.
Any other questions? Thank you, Dr. Lee.
All right, thank you.